Recording. Morning, everybody. So, it's not you who's joined us here on Zoom as well, is it? No. Oh, okay. No, just saying because I know yours. I think yours also shows iPhone. But I'm not sure. I'm just saying. Oh, okay. No problem. So today we're going to cover facial trauma and facial X-rays. All right. Now, the reason why I like to cover this one is because if you take a facial X-ray to a dentist, third year, just finished anatomy, and you give it to them, they can read it. Take a facial X-ray to a doctor who's been in practice for 30 years, and their face goes a bit funny because we've never been taught how to read it. All right, we've never been. And facial fractures and facial injuries are not exactly uncommon. It's not like when there's an accident, a magic shield comes in front of your face and everything else gets broken. You know, if somebody comes to hit you, all of us can dodge and get hit. We all get trauma. We all get hit, and doctors don't know. It's not our fault. It's the university's fault because they teach us when we do ENT. I don't know about you guys, but when I studied ENT, it was a 2-week block where you went and sat at home and you just wrote a small exam at the end of it. They didn't even know who you were. You didn't know who they were. And that was the end of it. And occasionally, if you went to the dental building at Medunsa because you wanted your teeth removed, one of the excited dental students would teach you a little bit about facial X-rays. All right. So that was the only that we learned about. Okay. So this is just something to teach us how to do it. So the truth is that you can have facial injuries in any scenario. That's basically what this means. You can have a facial injury from everything, anything. You can have a facial injury from falling down, facial injury from sports, from beatings, whatever it may be. So don't ever exclude facial injuries. Now we're going to start nasal injuries, just simple stuff. All right. So nasal deformities, generally quite obvious, quite easy to see. All right. The most important thing with nasal injuries, don't forget the surrounding tissue, because it's very easy to forget that. You know, you've got orbits around there, you've got an alveolar ridge. Some people just concentrate on the nose if they see there's a deformity, you know. So don't be somebody who does that. Always make sure you look at the surrounding tissue. Right? Now, this is something that a lot of people think that they need to do. Because in Hollywood, when somebody goes into an emergency department in a movie, what do they do? Some weird thing like that, agree? So a lot of people, unfortunately, have learned Hollywood medicine as well. So I've seen doctors here also attempt some sort of a reduction. People feel they've got to put some weird cross tape, or you know, they've got to do something for this nose. The truth is that you don't need to do anything for a broken nose in the emergency department. There is nothing. It's going to swell, and that swelling is going to reduce. There's going to be a deformity, and that deformity will be fixed by an ENT or a maxillofacial surgeon at some point. The problem is by you moving things around, trying to do this, trying to do that, you're actually going to create more complications for the patient. Number one, the patient feels the problem is sorted out. So now when they've got a nasal septum that's no longer aligned and getting severe sinusitis, they may not put 2 and 2 together and realize where it came from, right? Severe migraines, you know, all of these things, these complications that you can get from there. So don't do anything, just leave it. Analgesics, follow up at an ENT, max-fac, and they take it further from there. Okay, most importantly, anti-inflammatories. Okay, the only thing sometimes that you have to worry about is severe epistaxis. Okay, so we all know Heiselberg's plexus in the nose. You've heard of it, right? What's the arteries? I know everybody knows it. So you've got the sphenopalatine, you know, you've got all of these, the palatopalatine, you know, there's so many of these arteries that run through there, right? So they all form a crisscross pattern on that side of the nose. So the problem is if that gets disrupted, then you're going to bleed quite a bit. Now, the majority of the time, when you do get a transection in that area, if you can imagine, this is, for example, one of the arteries, let's say the sphenopalatine, generally you get a transection in this plane. So it's a transverse transection. So simple pressure, packing, all of that will be fine. And you'll stop your bleeding. The problem is that if you get a longitudinal transection, all right. Now this normally happens with the force that's applied in this direction, all right. So what happens is the artery gets squished and then it starts to rupture along that plane. So when that happens, it's a very large area that actually opens up, almost like an aneurysm bursting. So with those ones, what happens is that you can't actually pack them. All right. Normally for epistaxis, we pack things in, we apply pressure, we do things like that. And we don't know how high the transection can go. So this is like a one in a lifetime patient. You will work in an emergency department your whole life. You may only see one of these patients that develops one of those, but you still need to know what to do. If you have one of those, you're packing, you're doing whatever you want, blood is still pouring out, posterior bleeding, whatever it may be, this patient needs theater urgently. The simple reason being you have to physically stop that bleeding, clamp those arteries, cauterize those arteries, so that the patient doesn't bleed. Okay, let's go. So this is a rare complication that we see sometimes in the nose from injury. It's called a septal hematoma. All right. Can you see that little grape-like structure over there? All right. It's just like a little protrudence. It's not something you see very often, but you do see it. Now, the main problem with this is that if you leave it untreated, it causes a saddle nose deformity, okay, which is not a major issue. It's more of a medical legal thing. Because, I mean, listen, if you're working in Nutu, or if you're working somewhere on the Cape Flats, nobody's going to care that they've got a saddle nose. But when you see those ladies who live in Camps Bay or Sandton or Mflanga, and you're doing a locum over there and you leave them with something like this, you're going to be paying medical insurance in the millions, you know what I'm saying? So it's just something to keep an eye on. So what happens is you get your septum and you get your mucous membrane. They're tightly attached to one another. And your vascular supply is in the mucous membrane. So what happens is it starts to bleed and it starts to separate, okay? So you start getting the separation of the mucous membrane from the septum. And as it separates, it's removing the blood supply. So the septum dies. And that's why this happens. All right. It also has physical complications, also sinusitis, recurrent migraines, recurrent sinus headaches, you know, things like that, difficulty in lacrimation, possibility of a close angle glaucoma, you know, things like that. So you don't have to be careful, but it is a rare complication. So what you do, if you ever see this, you just make a little nick. You just cut it, just there. Let that blood drain out, that hematoma drain out, so the mucous membrane falls back onto the septum, blood supply is restored. And then for that bleeding, we just pack it. Simple enough. Right? So it's not a common thing, but it does happen. Now, what do you do with complex injuries? You can't fix everything. All right, remember that. Our job in the emergency department, stabilize, make sure the patient is fit for theater, make sure the patient is not dying in front of us. All right. Now, if you look at this patient, ophthalmic injuries, maxillofacial injuries, ENT injuries, possible dental injuries, I don't care how much you suture this. It hasn't sorted out anything on the inside. Agreed. It's also Hollywood medicine. In Hollywood, if you remove the bullet, somehow the liver magically repairs. The hole in the bowel is gone. You know, the pneumothorax magically expands just because the bullet came out. So we don't practice medicine like that. Yes, exactly. So covering up the surface wound is not going to do anything. Do you understand what I'm saying? So there are certain injuries that we can't do anything about. The most that you would do for something like this, X-rays, tag the skin, stop severe bleeding, CT the patient, and get the patient ready for their subspecialties. One thing I always tell people, if an obstetrician doesn't know how to treat depression, that's not a bad obstetrician. And if a psychiatrist doesn't know how to deal with preeclampsia, that's not a bad psychiatrist. Medicine is vast, medicine is broad, medicine has a lot of intricacies. That's why we all have our little specialties. Work within your specialty. Don't be a hero. You may cause more problems than you solve. Okay, right. So let's go to this. So these are nasal fractures again. We're getting to the meat of it just now. I just wanted to show you a few of these. All right. So the first thing you notice, if you suspect a nasal fracture and if you ask for a facial X-ray, can you see how prominent the soft tissue is? All right. So you need to ask specifically for that. You need to tell them specifically that you suspect a nasal fracture. The amount of radiation passed through the patient is much less. All right. So it gives you a better view of this nasal bone. Okay. It's a very thin bone. It's missed on normal X-rays. And if you look at most of our facial X-rays, you can't see that nasal bone just before the septum. So once you do that, then it's quite easy to see these, displaced nasal fractures, not non-displaced, and comminuted as well. But this is how it looks. Okay. So remember, if you suspect it, don't ask for a facial X-ray. You will never see the nasal bone. Explain right there, suspected nasal bone fracture, right? What you might call it, nasal view. You can put it like that if you want. So they know they've got to shoot a much lighter view through it, an underexposed view, so to speak. All right. So you'll see the soft tissue much better. Okay, got it. Right, now we get into the main part of it. The reason Jashin is on his phone is he's seen this lecture before. I think he's tired of it now. Yeah, but it's a good revision. And it's how many patients has it helped you see? A few. Now you start to see the facial trauma. Right? So when we want to look at the face, now I'm going to ask you, what is your face? Simple, what is your face? Yeah, everybody says this, but what is it technically speaking? This is your skull, all right? This is your mandible. So your face is alveolar ridge, zygoma, and the top of your orbit. So this is actually your face, okay? This is all skull, this is all mandible, all right? So which bones are we looking at? We're looking specifically at the zygoma. Does everybody know the zygoma? Okay, for those of you who don't know the zygoma, the reason why supermodels are on the covers of magazines are because they have very prominent zygomas. Agreed? Okay, so Kimi, when your boyfriend is looking at pictures on his phone, he's just admiring a nice zygoma. So go next to him and laugh. Right? I've also got a zygoma. What the hell are you looking at? Right? But literally, that's what we are looking at. Right? And then we're looking at the alveolar ridge, which forms the bottom of the zygoma. We go up to the temporal sutures here, and then the frontal suture, and we just look at the top of the orbit as well. Okay, so that's all that we're looking at. But that's the part that we're not trained to look at as well. So when we're looking at this, there are basically 3 lines that we are following. Now, these are delineated 1, 2, and 3. Now, what I'm going to do is, let me show you first this one, right? So we're going to follow it on the X-ray, and then you're going to look at where I'm pointing on my head as well. So we're starting here, all right? And we're going up above my eyebrow, and we're coming to here. So this is what we are looking at in the line number 1. So we are looking for injuries to the top part of the orbit. Line number 2, we're starting at the top of the zygoma, more or less just around here, all right? We are following through to the bottom part of the orbit. We're following along the bottom edge of the orbit, the medial side of the nose. So that's what we're looking at there with line number 2. And then with line number 3, we're looking at the bottom of the zygoma. We're coming along the bottom of the cheek, and then we're coming down to our alveolar ridge like that. So those are the 3 sections that we are looking at. Okay. Now that particular view is called an occipitomental view. Occipitomental. So they shoot through from there to there to give you this view of the face. The occipitomental view is very good because it gives you a nice view of line number 1 and line number 2. So in other words, if you suspect injuries here or you suspect injuries here, it gives you a very good view of that. The problem is that it doesn't always give you the best view of line number 3. So if you have injuries more towards the bottom part, you ask for something called an occipitomental 30. All that means is that they turn the head a little bit higher and they shoot through from a bit lower. So what happens? Normal view, you're looking at everything from here. Now you're looking more at the bottom. So we're still looking at line number 2, and we get a very good look at line number 3. Okay, so that's basically what the 2 views do. Now we're going to practice this over and over again, all right, in a few examples. Okay, but that's if you can remember this, even if you forget everything else and you remember this, then you'll know what's going on. So just to go through what we get. So essentially, we're now looking at fractures of the zygoma. So it consists of the arch and the body, right? So we are looking at the arch, which consists of the lateral and inferior orbit. The body is the malar eminence, your cheek, essentially, all right? So the way this thing is designed, if you look at it, it's actually designed like a cone, like an ice cream cone, with this being the opening of the cone and then the thing sort of, going into a point at the back, all right? Now, whether you're an atheist or a believer in God doesn't make a difference. I'm just telling you, this thing is beautifully designed, all right? The reason being, you have one eye per side, okay, which cannot regrow. However, you have bones that can regrow. The whole point of the structure is that if there is pressure onto this part, if all that pressure was directed towards your eyeball would pop and you can't get your eyeball back. So the way it's designed, it's actually spongy and expandable and fragile. So any force that hits the eye takes it and shoots it back out again. So it fractures everything around, preserving the eyeball, but dissipating the force and fracturing everything around. And if you look at this, it's a ring. Can you see that? Anybody got a ring on? No. Imagine a donut. Can you break a donut in one place? No. If you break one end, chances are another end is going to break. So this is exactly what happens with zygomatic fractures. If you have one fracture, chances are you've got another one. Chances are you've got 2 or 3. Do you get what we say? Because it's a ring structure. So most of these are called tripod fractures because 3 areas. Okay, so it can happen in any place, but these are the most common: frontozygomatic, inferior orbit, medial orbit, and then at the temporozygomatic suture over there. So those are the most common places. All right. So now we're going to look at some X-rays. If you guys are having trouble here, I'm talking about the guys who are here, well, are welcome to come and stand behind me. If you can see it from there, that's fine. But I think it may not be the best reflection over there. So I leave it up to you all. Okay. So what we're going to do is we're going to follow line number 1. All right. So I want you guys to tell me, and the guys on Zoom are also welcome to say if they see anything. All right. So what do you, just tell me if you see a fracture. First of all, how does this X-ray look? Not too bad, isn't it? Looks quite okay. All right. But let's have a look at it and see. So we are following on the top of the orbit. So we started the frontozygomatic suture. We go across, we jump over the nose, and we follow across onto the other side. Do you notice anything? Sorry? There. All right. If you look at the two sutures, you compare them to one another, you start to see that there's a bit of a widening over there. Okay. So we can assume that the trauma has happened on this side. Okay. Let's follow line number 2. So we're starting at the top of the zygoma. We follow across to the bottom of the orbit, and you'll notice it's a nice transition. You know, they tend to be in line with one another. Okay, so you follow across. Let's go over the nose, and let's come here to the bottom of the orbit again. And what do we see? Here, very good. So there's another fracture there, through there. So far we've got a fracture line that goes from there to there. Let's go across the bottom of it. Right. So the alveolar ridge, as we say, we don't expect number 3 to be too good. But what I expect you to notice this lovely arch that the alveolar ridge makes. Yeah? Now let's follow that across. So we're also looking at our teeth, we're looking at everything there. And let's come across to that arch on this side. What do you notice? Okay. Can you see those bones going up and down like that? I know it's a bit difficult on that one. If you're finding it hard, you can come and look at it on this picture. It's a bit more. So, okay, come. I think it might be easier because I know it's not the best projector. My brother warned me. He said, you know, this is a low resolution projector, but I looked at the price of the high resolution projector and I said, I don't have a half a month's salary to spend on you guys. You know? So let's have a look at it here. So look at this arch here. Okay, have a look at there and have a look at this arch. Do you see that? Mm-hmm. Look at that, all of that disruption. And the only one that we missed was this one. Can you see there's a fracture line through there? Oh, yeah. Right. So 2 minutes ago, this guy was going home, NAD. Today, we've got an entire face that's dislocated from the rest of the body. Right. So you understand how important it is to know about facial fractures. Okay, we're still going to do more examples, but I just wanted to show you guys so that you can see how important it is. Okay. So this gentleman now has got a face. Basically, this entire part of his face is detached. It's not attached to anything. What structure is it supporting? Mainly sinuses, eye. So if this starts moving away and collapsing, what's going to suffer? The eye, for one, it's going to start collapsing into that cavity. It's going to desiccate, and eventually it's going to lose that eye. And number 2, the sinus itself. Now you have an open area for infection to spread. He's eventually going to get severe cellulitis, osteomyelitis. You basically condemned him to either death or her, you know, or months and months in hospital. Okay. Say it this way. Sorry. All right, no problem. So this is one that's showing all the fractures. All right. So I know, like I said, it's not the easiest to see there, but anyway, those are all the fractures that we have. All right. So we're going to try another one. Okay. So I want you to just take note of these 2 things. Now the trauma is all on this side, okay, because I've already told you to look at the right orbit. But let's just follow the lines. Okay. So if you follow this line across, what do we notice again? Similar to the first one, isn't it? Can you see we've got a fracture there? All right. Let's follow the second. So we start at the top of the zygoma, the bottom of the orbit. We go across, we come here. Does anybody notice anything? What do you notice? Very good. You can see the disruption over there. In fact, if we go a bit further, can you see the disruption there? There's a fracture line there as well. All right. And then let's go across the bottom one. In this case, you can see there's not much on that except for this fracture over here. Right? So what's this at the top right-hand side? That's one question, all right? And what's going on in the sinus over here? That's another question, because it doesn't look normal compared to that side. Okay, what do you think this is? It's A, all right? That's orbital emphysema. You're not supposed to have air in your orbit. So how can air enter the orbit? From your sinuses. So if it enters from your sinuses, that means you've got a fracture into your sinus. So you have a facial fracture. The reason why I say this, these are lovely x-rays. These are meant for teaching. In the real world, the radiographer is not feeling too well that day, doesn't feel like resetting the machine, just shoots through. You get what I mean? So you have to look for subtle signs as well. And for instance, the only one we didn't see, there's this tiny fracture here. That could be the only fracture on this face. And you are developing orbital emphysema. So orbital emphysema is called the black eyebrow sign. Black eyebrow, or the eyebrow sign, whatever you want to call it, because you're not supposed to have an eyebrow on the X-ray. Okay, got that. Now, the other thing that we notice in between the two sinuses, we've got an air fluid level on this side. Okay, sorry, I did this long before I really knew how to do PowerPoint properly. That's why this thing shoots off to there. My apologies. But you, so this is a teardrop of tissue. What we're going to see it better just now. So what's happened is that the floor of this orbit has cracked. And when it cracks, all of that fluid and tissue falls down. Just like if the floor cracked here, we'd all start falling down. So that's what happens. So the first thing that happens, all that fluid goes down and it starts to fill up the sinus. So you can see the two sinuses are not the same. Now, this is in the setting of facial trauma. If your patient comes with a stab wound to this side of the head and you see a sinus that's full, that's not an orbital fracture. He has sinusitis. Do you get what I'm saying? Don't send him out a CT face. Everything must be seen in context as well. Okay, but these are two things that you need to know. All right, so we're going to look at these a bit more closely. So this is orbital emphysema on a CT scan, right? And we've got a fracture going into the sinus over there, right? Now, and this one here is just showing you the tissue. So all that tissue falls down as well as the fluid. So as the tissue is falling down, it's pulling the eye with it. So eventually that eye is going to get trapped inside. And when the globe gets trapped, the globe is very fragile. It's going to rupture, it's going to leak all that humor out, the eye is going to die, basically. Right? Now, everybody, do you remember which muscle runs along the bottom of the orbit? Just in the center. It's called the inferior rectus muscle. Do you remember its job? That is to help you look up. So when these patients have facial fractures, the first sign you can see, even before you do any sort of CTs, X-rays, anything like that, ask the patient to look up. So what happens is because that inferior rectus is trapped, it can't do its job. So you can see with this lady, the side that's not affected, eye moves easily. Side that's affected, she can't move it. Can you see? Right. So it's one of the first clues to the fact that there may be an orbital floor fracture. Guys got it? Okay, good. This is something for interest's sake. These are called Lefort fractures. You'll hear this term bandied around, especially if you do trauma. You don't have to remember all of them now. This is just nice. To be dead honest, most people don't actually remember the numbering. Even if you just say this is a Lefort 2, they'll nod and go, oh, okay, which one was Lefort 2? You know? You sound very smart. Yeah. But essentially, Lefort's ways of describing entire sections being, fractured of the face, all right? As compared to how we were looking at it, now you're saying it's an entire section. So Lefort 1, which is this, is essentially a fracture along that entire section. So it can be one side, but I mean unilateral, bilateral, right? Lefort 2 is from the nasal tip right down to here. And Lefort 3 is basically a dislocation of the entire face, right? So in other words, the fractures run not just superficially where we can see, but even in the posterior sphenoids, the greater, lesser sphenoid, all of that get involved. So what happens is that face is no longer connected to the body, okay? So one of the first clinical signs for this is facial bones moving. So your patient comes in, first of all, there's always swelling, discrepancy, so it's difficult to tell from there. But when you're trying to intubate, you notice that the teeth just keep on moving up and down. The nasal bone always seems to be sagging. When you press it, it moves around. This should alert you to the fact that these are possible Lefort fractures. They are diagnosed on CT. Nobody can tell you clinically this is a Lefort 1, 2, and 3. So you ask for a CT, right? One of the only ones maybe that you can pick up is this one here. It's called a dish face, right? So what happens is when you have bilateral Lefort 3s or unilateral Lefort 3s, because that face is not connected to any other structure, as soon as the patient lies down, it falls backwards. So they get a very flat face. Okay. Normally you can notice it if you stand at the head of the bed and you're looking over the patient's forehead. You would see one side is very high, one side is very flat. Okay. So that's one of the clinical things that you can look for. All right. So let's go through. There's just a few more to look at. All right. So this is the mandible. Everybody remembers all of this. All right, so I'm not going to spend time on that. No, I'm just joking. Everybody forgets the mandible. All right. But it's good to remember it, okay? But we're just going to look at some common fractures of the mandible. Okay, so can somebody help me find the fracture? Ah, very good. Right, so what do you do next? Just a simple question. I mean, what do you do next? Dr. Masondo, if you were to see this, what would you do with this patient now? Very good. Book for maxillofacial, make the appointment, send the patient home, analgesics. Agreed. All very good. Thank you. Right. So what if it's an open fracture? Nobody checks for this. It changes the management completely. With any fracture, if the fracture occurs on the hand, we always see, is it an open fracture or a closed fracture? But with the mandible, everybody forgets. That's why I ask. Now, what's the dirtiest part of our body? Even worse than our anus is our mouth. Your mouth contains 500,000 times more pathogens than the mouth of a dog. So once your patient has an open fracture and you send this patient home, what are you sending them home to get? Osteomyelitis of their jaw. What are they going to do once they lose their jaw? They are going to go for a commando procedure. Have you ever seen a commando in ENT? They remove the entire jaw, take it out. Gone. That's it. Look at grafting, look at doing all of those things from a simple fracture that can be treated with antibiotics and a bit of debridement, an urgent transfer to maxillofacial. We have to know these things. Don't worry. The answer you gave is the answer everybody gives. So what I'm saying is when you have a mandible fracture, don't automatically assume it's just a minor thing. Go and check them out. If it's an open fracture, patient requires admission, IV antibiotics. You don't have to transfer to max-fac at the same time. Either dentistry or surgery in our setting will transfer to maxillofacial. It's not a dire emergency as we transport in the middle of the night. It just needs to start on the right treatment. As compared to a closed fracture, no problem. Closed fractures can sit there for weeks. There's nothing going to get into that bone. Patient just needs analgesics and eventually fixation. That's it, nothing else. But what I'm saying is if you treat everybody as a closed fracture, you're going to condemn some of your patients to months and months and months in hospital, literally, because it's not easy to graft bone. It's not easy. For them to reconstruct a mandible is difficult. And to leave a patient without a mandible, can you imagine living without a mandible? You can't eat. You're on a nasogastric tube all the time. You look horrified. Do you get what I'm saying? You're never going to get back your face. You get what I'm saying? So be careful of those things. All right? So these are just some signs you can use, clinical signs. If you see a sublingual hemorrhage, it's pathognomic of a mandible fracture in the setting of trauma. Okay, in the setting of trauma. So if your patient comes with palpitations and you find this, your patient has got a bleeding disorder. Please do not diagnose them with a mandible fracture. Okay. A normal mandible can bite a tongue depressor until it breaks. In other words, you can bite it and break. If you've got a fracture, you can't do that. It's too painful. And all of us can rotate our tongue along our molars. Do it now. That's fine. Not painful at all. When you've got a fracture, you can't do it because of the glossal insertions. Okay. So just remember. So let's do another one. Where's the fracture? Very good. Right at the top over here. Right? So this is what they call a coronoid fracture. Very rare. So always remember, look right through the entire thing. All right. It's also a very complicated fracture to fix. That's why I mentioned. And generally they tend to be open, but we can't see because of where it is. Okay. So whenever you get those, refer as quickly as possible. Okay. All right. So it's much easier when you do look at the whole X-ray. Right. Now let's look at this. Where's the fracture? Very good. Right. There, right. So you've got two fractures over there. What's the first thing you're going to check now? Whether it's open or closed. All right. Let's say this is a closed fracture. What are you going to do next? Discharge on Panado Tramadol, dental appointment the next day. Yeah, that's what we'll do. Okay. We don't book max. Yeah, we don't. Yeah, ENT surgery should do. Now let me ask you, what is this piece of jaw attached to? What's it attached to? This piece. What's supporting it? Nothing. Agreed. It's just lying over there. What happens when this patient lies down that night? I'm going to fall down. Agreed. What's it going to compress? His airway. Still sending him home, Ronaldo and Tramadol. It's essentially a flail segment, right? Like what you have a rib flail segment. Even if you have a single rib flail segment, you don't send your patient home. Okay. This is an unsupported piece of bone right around in a vital structure, which is your airway. Now, this particular one is not at much risk of collapse, but it's just to illustrate the point. Okay. In other words, we won't send the patient home. We will involve max fac dental surgery and say, listen, this is the problem. If they say the patient can go home, that's fine. Because some of these patients, they advise them to nurse themselves upright. You know, in other words, they must sleep upright and things like that. But it's not our call because we're not specialists in that area. The one that's the most worrying is when you have bilateral angle fractures. Because from that angle, that entire thing just falls down. And those patients in the middle of the night stop breathing and they don't know what to do. The other problem is the glossal muscle attachment. So the entire tongue just goes down. As soon as it collapses, the tongue just simply retreats. It follows the mandible, so it goes down. And these patients suffocate to death in the middle of the night. Okay, so be careful. All right. Okay. So that just to point that out again. So we're coming now almost to the end. Right. So this time we're looking at an OM 30. Right. So that means we're expecting fractures somewhere towards the bottom. All right. So we'll start with line number 2. So line number 2, we trace along the top here. Right. Let's come across. And let's see if there's anything that we notice. So we start here, top of the maxilla, bottom of the orbit, nasal bones, bottom of the orbit. Notice anything funny? What's funny? All right, look at this side. Look at the top of the maxilla, or the zygoma, sorry, I'm saying maxilla. Top of the zygomic, no, it is, yeah, the prominent, and how it goes onto the bottom of the orbit. Okay, now look at this side. The bottom of the orbit, what's missing? You may not be able to see it too well over there, but basically, there's no bone here. That entire piece is missing. Here it is, here at the bottom. All right. I know it's a bit difficult to see on this. Maybe if you rewatch the lecture, you'll see it a bit better. All right? And then we follow line number 3 at the bottom. And when we come across, we actually see this again. All right? So even if we notice the X-ray, we can see there's a large amount of tissue swelling on the side. So basically what happened here is this entire side of the zygoma and the maxilla and all has been pushed back. All right? Quite severely, and it's now detached from there. There's always the possibility of having mandible fractures, and in this case, and remember what we said, if you have 1 fracture, chances are you have 2 fractures, chances are you have 3 fractures. So even if you just pick up a single one, this patient deserves CT of the facial bones to see where this may be. In his case, he also had a small frontozygomatic fracture as well, right? On CT, you'd probably find more fractures inside. So what I'm saying is be careful when you read these X-rays. And if you're not sure, rather ask. There's no harm in asking. Nobody's going to laugh at you if there's nothing there. They'll actually be happy that at least you looked and at least you saw. The main complications from these things, disfiguration, sinus issues, but more importantly, the eye. Right? The eye is the main structure that's sitting in that area. So that's what we need to worry about. Okay. Then, of course, you've got the brain posteriorly. You've got a lot of blood vessels, massive blood vessels that run in that area. But these are less common complications. Okay. But what I'm saying is, even a person walking, talking, fractures lines all along here that you send home, in 2 weeks' time, is going to come with a little eyeball that size that's desiccated completely. Now has to be enucleated, now only has 1 eye. Do you get what I'm saying? So you don't necessarily kill the patient if you miss it, but you're going to cause them great harm. You get what I mean? So this is our duty as doctors. This is why we learn, so that we don't do harm to our patient. Okay. So ask, there's no harm in that. This is the last slide. Okay. What will you do? I'm telling you, you do not touch this. You don't do anything for this. You keep the patient comfortable. We don't know where this thing is going. Again, in Hollywood, some doctor walks in, walks back to the tea room, solved everything. All right. In the real world, you've got you've got maxillary injuries, you've got potential palatine injuries, You've got potential C-spine injuries, vascular injuries. We don't know if this has other spikes. Is it going into the brain? Has it affected the orbit? Has it affected the eye? We don't know. It may be tamponading a vessel. Let's say it's lying against the internal carotid or one of the paraspinal arteries, and it's tamponading it, and you move this. The tamponade is gone. How are you going to compress that area? You'll have to grab him around the neck like that and hold him. Agreed, until he dies from asphyxiation. At least he won't die from exsanguination, but you die from asphyxiation. Agreed. So when you see things like this, do not touch it. These types of things, foreign bodies that are going through the face, imaging, multiple subspecialties need to be involved to decide what to do. And when you say imaging, you're talking about CT angios, you're talking about what you might call it MRIs if it's a non-metal object. You know, there's a lot of things that you need to be worried about. Okay, the same applies for a foreign body stuck in the palate. Kidneys, for example, we've had one or two over the years. You know, playing around with pens and things like that. The pen goes right through to the back. Now it's stuck in that palate. You can't just pull it out because you've got multiple vessels lying at the back of the throat. You don't know what it's hit. Agree? So you have to be careful with all of these things. So leave these alone. I'm talking about in the emergency department, right? If you do become a high-powered maxillofacial, please do not say, Dr. Mohammed told me I mustn't touch these and go home. All right, that's your job now. Okay. All right. So any questions? Anything you guys want to know? That's just a joke to finish. All right. So any questions, anything anybody wants to know, anything anybody is worried about? Because these are difficult. There's no doubt. And sometimes they are very subtle. I can tell you there are x-rays that I have looked at for like 10, 15 minutes. And I'm like, listen, there's something here, but I'm just not sure. You know what I mean? That's when we go to radiology and we say, listen, please give us a second opinion. And very often when the x-ray changes are suggestive, not conclusive, we still do a CT, simply because the eye is involved. You get what I mean? So better safe than sorry. Now, if you go to radiology, they look at hundreds of these per week. And if they tell you there's nothing here, agree and say no problem, but note it down. Spoke to Dr. So-and-so, said the x-ray is fine. Because if the patient comes back in 2 weeks, you've covered yourself. I asked somebody senior, somebody in a specialty, and they told me nothing was wrong. This is not to put down the other doctor, but just you've done your due diligence. Do you get what I'm saying? Otherwise, it becomes your fault. Dr. Biela didn't look at the x-ray properly. Dr. Sibeko didn't look at the x-ray properly. That doctor in radiology, I didn't see any x-ray. Nobody spoke to me. I don't know anything about it. You get what I mean? So always note down who you speak to. And when you find something, don't be scared to admit, because these patients are talking, walking, they're perfectly fine, but they are going to have complications in a week's time. Nobody will fight with you if you admit these patients. Okay, got it. So any questions? Anything I want to know? These are things you have to keep on practicing, these x-rays. So as I always joke with you, I make excuses. This is also one of those. Now, when you see my name, do a facial x-ray. Just tell the patient, I'm doing a facial x-ray for you. Guy got stabbed, they do a facial x-ray. Never mind. Just to practice, so that you get the chance to see those lines. And when you're not sure and you really suspect something, and then we look at it together. Okay. All right, no problem. Guys on Zoom, any questions? Are you guys okay as well? Don't see anything on the chat today, so I'm guessing everything's all right. Good. Right. Okay, so we'll call that. Oh God, that was a long one. I'm sorry, man. 40 minutes. All right, we'll try and keep the next one short. All right, but I think the Friday one is a bit longer, more because there's more involved topics in what we deal with, the ECGs and the ultrasounds. Right? So maybe our Friday ones will be a bit longer. All right, but yeah, I think we'll end it over there. And right, let's get back to work. And for the people on Zoom, thanks very much. Bye-bye.